Good morning, everyone, and very warm welcome to this incredible event. It is an honor and privilege to be your host for this conference. Myself, Dr. Santanlashmi, and she, Dr. Anureka, are absolutely thrilled to be your host today, bringing you a spectacle of talent and excitement. And now we are going to start our session one, and I like to call a chairperson for session one. Dr. Moti sir, General Physician from Sri Narayani Hospital, Vellore, and Dr. Ravindranath sir, MG from Narvi Hospital. And I would like to call upon the speaker, Dr. Kishore Kumar sir, to start his presentation. And it's a small CV about the Kishore sir. He's a consultant in gastroenterology at Vinayaka Mission Super Specialty Hospital, Pondicherry. His clinical expertise covers inflammatory bowel disease, functional bowel disorders, liver and pancreatic diseases, with a strong emphasis on preventive health and patient-centered care. He has published 4 research papers and has been actively involved in clinical teaching as well as academic discussion. Thank you, sir, for coming here for the presentation. Let's start the presentation now.
வணக்கம். ஃபர்ஸ்ட் நான் டாக்டர் மோகன் ராஜ் சாருக்கும் டாக்டர் மோகன் சாருக்கும் தேங்க்ஸ் சொல்லிக்கிறேன் சான்ஸ் கொடுத்ததுக்கு. தேங்க்யூ சார். இட்ஸ் மை ஃபர்ஸ்ட் presentation. Sure. So we'll start this session. So evolution of acid suppression therapy. So history is a good teacher. Unfortunately, it has no students. I think I will try to make some students today. So before jumping into the topic per se, we will see the physiological overview of acid production. So generally stomach divided into 3 anatomical parts: fundus, body and antrum. So into this functional area, it can be divided into 2: oxygenating gland and pylori gland area. So we can see in the oxygenating gland area, it shows it has parietal cells, B cells, the enterochromatin cells, chief cells. In the pylori gland area, you can see most of G cells. So it secrete gastrins. So acid production was mostly controlled by 3 pathways: one neural pathway, and hormonal pathway, and paracrine pathway. Neural pathway is acetylcholine, acts via M3 receptors, and gastrin comes to hormonal pathway, acts via CCK2 receptors, and the paracrine pathway, like histamine, acts via H2 receptors. So this is the overview. So we can see the pylori gland area. So pylori gland area. So the endocrine system secretes gastrin-releasing peptides. It will act on G cells and secrete gastrin. It will stimulate the parietal cells for acid productions. We can see the enterochromatin-like cells producing histamine. It will act on H2 receptors and triggering the parietal cells to release HCl. So to look into this evolution, we have to jump back to 18th century. So initially, many physicians and many scientists thought that the gastric acid contains lactic acid before 1823. In 1823, William Prout discovered that gastric juices contain mostly HCl, which is helpful in digestion. Then in 1833, William Beaumont, father of gastric physiology, studied the physiology of digestions and helpful HCl in digestive process. Then comes in 1881, the surgeon Ludwig Reidiger performed gastrectomy for gastric ulcers. Previously, Billroth 1 and Billroth 2 was performed for gastric antral CAs, which is causing gastric outlet obstruction. In 1881, Ludwig Reidiger first performed the gastrectomy for gastric ulcer causing gastric outlet obstruction. Then comes the Ian Pavlov. In 1897, he made a study and assessed the neural schema behind the gastric acid production in 1897. Then comes the first antacid. In 19th century, they used for gastric acid suppression was antacid. Antacid first compound used for the acidity. So mostly there are alkaline compounds used to neutralize the acids in 19th century initially. So okay, what are the advantages and what are the shortcomings of the antacids? So it provides immediate relief. Yeah, we all know antacids provides immediate relief, but the disadvantage was short duration of action. We can't use for long-term use, and it can also cause electrolyte disturbance. It causes more of the constipations and diarrheal complications, and it can also cause a rebound acid production, and it has no direct effect on acid suppression. It just only neutralizes the acid, but no effect on acid production. That's the one problem. So then comes in 1910, Carl Schwartz, a surgeon named He thought that no acid, no ulcer. If there are no acid production, there won't be any cause for ulcer. He thought that acid is the main culprit for ulcer formation. So followed by his fellow, 1915, Welton Sippy formed a regimen called Sippy regimen in 1950. So what he does in that regimen? So he asked the patients to go for hourly milk and cream feeding and periodic gastric aspiration with a Evol's tube and large dose of antacids. He used to give large dose of antacids. He thinks that it will hasten the healing of ulcers. So what was the shortcoming? So yeah, it's a good idea only, So we can use large dose of antacids and we can aspirate the gastric acid. So that way we can prevent the formation of gastric acid. So what was the shortcoming? So do you think? So we can't put everyone trials tube and we can't go on aspirating gastric acids to hasten the healing. So that was one problem. It's a little bit invasive, I think so. So in 1943, so till then they are using antacids to suppress the acid and to reduce the ulcer formation. So in 1943, surgeon Lester, he performed vagotomy first time for the gastric ulcers. So many of them doing vagotomy for in case of ulcers. So highly selective and truncal vagotomy. Today we are doing also. 1943, Lester's the first one to do. So what was the main problem with this? So this one of the things is also invasive. It's operational. So we can't push the patient to go for operative procedures for an ulcer unless until it is indicated. So in late 1940s they discovered anticholinergics. So I think atrofa belladonna was in use in 19th century itself, but it came into role for acid suppression in 1940s. So atropine was first used to reduce acid suppressions. So what are the other things? So it blocks the M3 receptor pathway, but it can block every other muscarinic and nicotinic receptors. So they want more specific like pyrenzapine, telencepine, and propanthalin. They introduced into late 1970s. So what was the problem in that? So positive things. So it inhibits actual production but does not neutralize it. Long duration of action that antacid, but the problems are slower onset of actions and systemic adverse effects more with anticholinergics. So we have to choose some other drugs. So in late 1960s they used also radiotherapy. So they used radiotherapy to kill the parietal cells. So they used 18 gray over 10 fractions. Yeah, it ultimately reduced the acid production by 50% in approximately 40% of the patients. But it effects last for 6 to 12 months. Then they keep on producing seroparietal acid production. So we can keep on going for radiotherapy because it has its own effects, radiation toxicity. So then this comes a turning point. In 1972, James Black, he discovered the histamine H2 receptors. That's also playing a role in the acid production. So he discovered the H2 receptor antagonist in 1976. The FDA approved came into role. The first year of H2 for clinical is simtadine. Then followed by came into ranitidine in 1981 and famotidine, roxetidine, and astatidine. This came subsequently. So yeah, it's a good action, faster onset of action. It's a more potent drug and easier to long-term use and minimal systemic adverse event compared to atropine. But it has a tachyphylaxis and inhibit only histamine pathway only. There are some other pathways that cannot be suppressed by H2 blockers. So why no H2 developed after that? Because developed tolerance and low commercial incentive and PPAs are more effective because inhibit the final pathway. So there was no more further development H2 receptor blockers. Okay, then comes the 1976, Charles Sachs. He discovered the hydrogen potassium ATPase pump. This is the final pathway playing a major role in the acid production. So followed by that, in 1988 only FDA approved. In 1981 they published the first paper, PPAs, but in 1988 only it got approved by FDA and came into commercial use. So we all know that inside the parietal cells, hydrogen potassium ATPase pumps will be in inactive form. So once it gets activated, hydrogen potassium ATPase pump will come and move to the canalicular membrane and start producing acids. So it will go and bind on the active hydrogen potassium ATPase pump only, but inactive pumps cannot be blocked by PPIs. So that's the problem. Inhibit final step and long-lasting action, more potent, low tachyphylaxis, but expensive systemic adverse effect and delayed onset of action when compared to PCAPs. So in between he made a discovery. 1984, Marshall and Warren discovered H. pylori. It's also a cause for the gastric acid ulcer formation. So in 2014, then comes the PCAPs. So we know that PCAPs can block potassium pumps in the hydrogen ATPase channel, both in active form as well as in inactive form. That's the one advantage when compared to PPIs. So it has a faster onset of action, more potent, meal independent, and the side effects are over suppression of acid. Yeah, everything is considered more over suppression of acid. Long term safety is still more not more available, and it's more expensive. Okay, fine. Then next it comes the stomatostatin analogs. So what are the pitfalls in somatostatin analogs? It's more expensive, only parenteral available, and systemic adverse effects. So we are not using somatostatin. Somatostatin can block the acid production very good, but we are not using in routine practice. And there is one called gastrin receptor blockers. The gastrin are via CCK2 receptors, so it can be blocked by some drugs called proglumide, loxaglumide, natazepide. But the pitfalls are modest acid suppression and poor oral availability. So these drugs also not in use, general use. So in summary, initially we use antacids, then comes the anticholinergics, then comes the surgery. Prior to S2 histamine receptor blockers, then after in 1972 S2 blockers, then 1988 first generation PPIs came into action. Then in 2014 it's PCAB era. Thank you.
Thank you for the good lecture on evolution of antacids. The discovery of antacid is one of the most significant findings in the medical history because it made a lot of difference. When I was a student, the most frequent surgery was GJ, gastrojejunostomy, because of the pyloric stenosis and because of the excess acid secretion and pyloric and gastric ulcers. But by the discovery of antacids, the incidence of GJ is almost nil now. So we are thankful to the discovery of antacids.
Yeah, thank you, Kishore. That's a nice, making from the beginning to today. It is a good talk, actually. So just say me, which one will you prefer as a gastroenterologist in a treatment-naive patient to start with? Are you really using antacids, syrups, etc. right now? We will start with PPA.
We will be using antacids as a rescue therapy, like in between midnight if the patient is having heartburns, that time it will be useful. Other than like routinely we used to use PPA or PCABs, and for rescue we can use because patient needs immediate relief.
Thank you.
Thank you, Dr. Kishore sir, for enlightening us on evolution of acid suppression therapy.